Right. Welcome to the Business of Allied Health podcast. I have a very special guest here. I've got Craig Phillips. You might not know him, but I definitely knew him in my early undergrad days at University of Melbourne Physio over 20 years ago. He is the founder of DMA Pilates, and he's the inventor, basically, of the name Clinical Pilates. And I think he even owns the domain name.
Yep.
The program.
And the copyright
And the copyright,
that sort of stuff.
all that stuff. So he's the man behind Clinical Pilates. And welcome, Craig. So I just want to pick your brains here in terms of what you've seen in the last 38 years that has changed in physio. What tips you give physios? Because the attrition rate's so high, right? 75% leave our profession after 5 years. And the question here is like, why are you still operating in this? Jokes aside, and yes, tell us your story, Craig. Like, how did you end up choosing physio that many years ago, etc.?
Right. I mean, I guess my main thing for those that don't know the pre part of that, I'm a recycled ballet dancer. Spent 10 years with the Australian Ballet before I went into physio. That was when I first started doing Pilates in the 90s, even longer, about 50 something years ago. So when I left the ballet company, went back to uni, started studying, went through university, came out, took 5 years to do it because I failed a year.
You failed it?
Yeah. I failed neuro, but I'm coming back to get them because I've actually got it wrong, I've discovered, with brain trauma and stroke. Yes, we've got some research going on. That's another story. And I guess this is one of the things that keeps me inspired. There's so many things to do and get done that, there's huge scope for this profession that I think is getting lost somewhere in the mix. So I went to uni, got out of uni, and being interested in the dance world, went to a lecture with a guy from San Francisco, a guy called Jim Garrick, an orthopedic surgeon, who said, we put Pilates in at St. Francis Hospital in San Francisco. He said, come and see what we're doing. I'd be interested in your input. He said, because we should be getting the athletes onto this. So this is an orthopod in the 80s. He was way ahead of his time. They were looking after the San Francisco 49ers. And he said, if these guys could do half of what these dancers could do, he said they would be less injured and probably much better athletes. So it started a relationship going backwards and forwards to the States and picking up on what I'd learned from Pilates in the years before that. And then we set up the first Pilates studio set up in Australia at Paran Sports Medicine back in the late 80s. And we were working with dancers, and of course we started working with AFL footballers, and that's where it started. And then we evolved into the clinical Pilates aspect of it, sharing. People wanted to know what this was about. And at that stage we were trying to work it out ourselves. But since then it's evolved, the clinical part of it, becoming very much a treatment tool. So it was exercise, which everyone was saying was a great idea. But it became the next stage of let's look at very specific exercises that can help injury. So we started looking at a lot of things like ACLs back then, where we had half the AFL running over with ACL deficient knees because they'd been putting in these carbon fiber Kevlar Gore-Tex grafts. They were rotting out, but these guys were still playing quite happily with ACL deficient knees. So there was a whole range of things there that became things for us to follow up on, which we then did. Winding forward, we then started teaching other physios what we were doing, and we now have Pilates everywhere. So we've trained some 25,000 physios or more. We've been training in Australia, we've been training in the UK. Singapore and Hong Kong are still very strong markets, have been for 25 plus years, New Zealand. So it's been a big uptake by physios. And then about 15, 16 years ago, we did start getting into the research, right? What's wrong with the previous research? It was all based around TA and core stability, and that was being disproven at that time. So we set about getting some researchers involved with Melbourne University, Otago University, had Cardiff University in the UK, trying to think how many universities. So we've got about 7 or 8 universities at the moment that we're working with. We've got PhDs coming out of Singapore, which has proven even more of what we're doing to work extremely well. So I guess this is where, with physios having a plan There's a lot of Pilates studios being set up, which general exercise, which is great for people doing exercise, better than doing no exercise. But physios are needing to step up that next level to show what their point of difference is. And I guess this is the biggest thing. What are physios doing differently from the general exercise groups, gym, strength and conditioning, and all the rest of it? There's also the big advent of AI physio, which only in the last few years has become a big thing in physio, with the NHS sort of dissolving a couple of years ago. The problem is they've now been taken over by AI physio, a thing called Flock Health, FLOK Health, which is just a bot giving out physio exercises, no physios involved. So this is a bit of a threat to the profession, meaning the profession needs to stand up and step up even further. Is that a starting point?
Yeah. So from what you've seen of Flock Health, is it a true threat, or is it just something we don't need to worry about? It's just one of those.
No, I think we do definitely have to look at it, because what's happened is a lot of physios are giving out protocols. They're just giving out a sheet of exercises. Here's a group of exercises. Everybody is the same. I shan't mention any programs, but they're very generic education. They're very generic exercises. And the thing is, you're not going to get everybody improving. Some will get better, some will get worse, some will stay the same. So a generic program will probably get a 30% hit rate. That's what comes out of the data. It means you're going to have about some 66% of people are no better or worse from the programs. So this is where we step in to say, you've done exercise program, you're no worse, you're no better, or you're worse. Why?
And just to play devil's advocate, why clinical Pilates as the form of exercise here? How is it different?
This has taken many years of
Yeah.
research. The thing with clinical Pilates is it's very specific. It looks at subgrouping patients. So rather than treating every patient the same, actually subgrouping. And this has been the point of our research over many years, is looking them into a directional load. Every patient is different, and that's been mentioned for many years, but people don't know what that difference is. So we have identified that difference, and the difference is everybody responds differently to directional load. And that's the key. We put this to the test. We did some studies out of Otago University. So the model of classifying patients into a directional load, and it's quite simple. You look at their flexion, extension, left or right. That's got a 0.87 kappa, so it's very high, near perfect inter-rater reliability. So we know it's a very robust model. And this is where you find in any clinician, when it comes to clinical reasoning, you'll find most clinicians, we've been seeing it in sporting teams, we've been seeing it in Olympic squads, in mums and dads, they have a pattern of injuries. That's one side. How many patients have you seen in your career, Barry, that have had all their problems on one side? Oh, it's my hip, it's my knee, it's my foot, it's my shoulder. It's all one side of your body. And this is the elephant in the room. It's an absolute elephant in the room. When you go to the highest levels of sport down to general public, is people are given bilateral, both-sided exercises for one-sided problems, so they cancel out. We've just put this to the test. I had another PhD, one of quite a few. This was run out of Singapore, and this was a double-blinded RCT, which is seen as the gold standard, except it was 3 arms. Now, they're the tough ones. A 2-arm double-blinded RCT is seen as the gold standard, placebo versus intervention. This one was a 3-arm double-blinded RCT, and it compared standard exercise, standard Pilates, and then the subgroup model that we proposed. And it came in for low back pain population. So looking at the number one worldwide cost problem, low back pain, it came in for function, disability, and pain at a P001 significant difference improvement over the other 2 groups. So we got it. We've now proven it. And that was done completely independently. My name is not even on the paper, which is good. But it does say in the title, DMA Clinical Pilates. So we know it's about, but we just left the university to do it, to come back and say, yeah. So there's a whole series of papers have gone along with it, and this has shaken up the low back pain world massively, which is good. It's thrown down the gauntlet.
Are physios learning this at undergraduate or master's level?
No.
Are they learning this type of skill, clinical reasoning process, framework approach? No.
Not yet. We are talking to some of the universities in Australia and overseas, is bringing some of this reasoning in at the undergraduate level because it moves beyond the pathoanatomical. You need to know the pathoanatomical understandings first, so you don't miss the red flags and the obvious ones. And yes, treat a structure, treat a pathology, and they get better. That's terrific. Where this stuff really hits the road running is when you get into that chronic phase. So if it's subacute and acute phase, you treat structure, sure, and they get better from treating structure. That's fantastic. Now, if you've been treating a structure 6 months, 12 months, 10 years, and it's not getting better, then we don't have a structural problem. So what is it? And this is where this stuff sets the ball rolling. You move pathoanatomy from the equation and you treat this directional model. So it's movement-based classification and treatment, which takes over from structure-based classification and treatment. And there's a lot of question these days about structure. Is it really a tendon? We're hearing with the tendinopathy people. Is it really a labrum? Is it really a Gans lesion? Is it really a spondylolisthesis? Is it really a disc? Is it really a rotator cuff tear? And is it meniscus? You look at so much of our pathology is related to structure, and then they've hit the chronic complex where all those structures have been managed and they're just getting worse. So this is where it becomes a much better model to then apply to. And then you go back and hypothesize as to what structure may be involved. But at the end of the day, you've got a very recordable measure. And as I said, it's got a 0.87 kappa, so we know it's robust and we know it's reliable.
So in a nutshell, if you look at a SOAP, like algorithm, subjective, objective, question, blah, 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 typical physio, how would you summarize what you do differently to what is being taught at the moment? Right. I think you commented on one of my LinkedIn posts about body charting.
Yep.
As a starting point, which is interesting because most physios, at least I've seen on my system, don't even use that anymore. In fact, anyway, I don't want to go down that path in this chat. So in summary, Craig,
it comes
step by step. Yeah. In a short form.
It's a very simple process. It's called heuristics. So in a SOAP situation, you do a very good subjective. Now, what happens with a lot of note-taking these days is there's too much. Biopsychosocial drives people insane because they look at psycho. If you move to the bio, it's actually very simple. We've got a proposed PhD coming out to simplify the biopsychosocial. But if you look at what you're measuring. So in your subjective, first thing is a body chart. Top to bottom, left and right. Don't just put a circle around the knee. I'll go insane. Because the knee may not be the primary problem. But this is the thing of going through, and I did it this morning. He's one of the AFL guy, and he's had a hip scope arthroscopy. Everyone's been treating his hip. And when you take a full body chart, he's got hip problems, he's got knee problems, he's got ankle problems, he's got shoulder problems, he's got back problems, all on the same side. So simple thing we can say even straight up, everyone's treated your hip. You've got hip pain, you haven't got a hip problem. So it's this unilaterality. One side is the problem. It's left or right. It's quite simple. The second stage is you're looking at 3 other bits of information. You're looking at ags and eases. Tell me. Everybody looks at ags and eases. And that also gives some good information because if it's aggravated by a lot of flexion, if it's aggravated by sitting in a car, bending over, that's an exclusion from treatment. If it's eased by extension, standing, walking, running, swimming, that's an inclusion in treatment. And the other big one we're seeing is trauma. Now in sport, a trauma can be, say, in AFL footy, this guy this morning, bending over to pick up a football. I did my hamstring, did my glute. That's a flexion trauma. I kicked the ball. Did my hamstring. That's a flexion trauma. So these are exclusions compared to inclusion. So you have a problem, you have a preference. And this comes from military thinking. As I said, heuristics, how fast can you make a decision in the military? How fast can you make a decision if you're a pilot in a plane crash? You need 4 bits of information, and that's a very reliable decision-making tool. Unfortunately, what we're being taught is you've got to include everything And as a result, nobody can make a decision. You throw a protocol at it, doesn't work, you can't think, and then you're confused. And this, I can say with hand on heart, is probably why a lot of physios are leaving the profession, because they haven't got problem and decision-making tools at their disposal to know how to treat a patient. And as I said, this chap this morning, it's been going on for 3 years. Everyone's treated his hip, it hasn't worked. So first thing, you don't do what everyone else has done and failed. So it's a very simple model. You hypothesize one side, one direction to treat. So it's unilateral, unidirect, test, intervention, retest. So this is where you test and you'll see an asymmetry. We talk about it all the time. There's an asymmetry. Can you address that asymmetry within session? And we've done this also in post-hoc analyses with Otago University, and the answer is yes. Within about 16 minutes, reliably, 26.9% change in proprioception. So we're getting away from strength models, which is we still use. Yeah, we still talk about strength, but I've yet to find a student who can tell me what a Cybex, Bidex, Medex, or a KingCom is. Do you know what they are? That was strength testing in the 80s and 90s. Peak torque, symmetry, asymmetry, quads, hamstring ratios. How much peak torque could you generate? That was strength. They don't teach it anymore because it didn't work. And we're seeing this.
Yeah. So what's your view about this? Like force plates?
Force plates are different. We actually use force plates for testing, looking at center of pressure and what have you, but actual peak torque grunt, if you look at it every year, pick the AFL teams where they've increased their strength and conditioning, they get an increased injury rate. We've been watching it for 30 years or more.
Right.
Increased S&C, and I know I've been slammed by people for this. You've got to have strength. I go, if you've got to have strength, why are you so injured?
Yeah, I've heard this from you off the
You'll hear it time and time again.
Okay. And on that point, as a basics, what do you need in a physio clinic to assess these things? Do you need what technologies, or do you video record this? Do you just need your eyes?
The one good thing from an iPhone
Okay.
is videoing it.
Okay.
As far as getting technical equipment, you can get, as I said, force plates and some of the dynamometry stuff that's used. Very expensive. I'm cheap. I use a $19.95 luggage strap from the airport. That'll tell me how much load is being generated. But this is where videoing the patient so they can see a symmetry or an asymmetry. Intervention, then you retest them and re-video and show there's a change in that symmetry within session. We do that constantly.
That's really interesting. So if you look at the strength testing and the measures are the same, it doesn't necessarily fix the problem, does it, for the patient?
No.
But there's more weighting towards a video recording. Is that what you're saying? Okay.
It's submissible in evidence in court if you want to get to that level.
Really?
Yeah.
Wow.
Because it's an objective measure. It's not an opinion.
Oh,
yeah.
Really interesting. And you've done all that stuff too, huh?
I'm involved in that. Yes, unfortunately.
Unfortunately.
Yeah.
Oh, really good insights there. Yeah. So video will save you more in court than readings from
notes.
Is that correct?
But if you do numbers, and this is where outcome measures come into it. Yeah. So we use outcome measures very reliably, lower limb function test, upper limb function tests. So then you can have a measure of symmetry or asymmetry, and then you do your intervention, and then you can measure the change in symmetry, patient-specific functional scales. So we're very heavy on using good simple outcome measures. Yeah, absolutely.
PROMs, patient report outcome measures.
Yep, PROMs. Yeah, critical.
Wow, this is really interesting because a lot of physio clinics now have or market VALD and all these force plates and things as their number one thing around making the claim that they're objective in their assessment.
They're objective, but it's also the position you're testing them in. And this is where you can do a positional test, say, of a hamstring curl in prone, but you change it by doing it center, left, or right, and get a completely different reading. It's called a positional response.
Interesting.
This is another PhD we've got in track right now as I'm speaking, which will be done it'll be done in Hong Kong, this one.
Okay.
Of looking at this positional response. So it takes the whole thing with strength testing, and we've done this with British rowing, GB rowing, 2012, 2016 Olympics, and shown that this directional load response incorporated into their strength and conditioning program. Have a look at their medal count in 2012 and 2016, GB rowing. They won't tell you what they did, but it was done as a master's. It was done by maybe physio through Cardiff University. Yeah.
So this research is published publicly and people.
That actual paper was never published.
Okay.
Because it worked and UK Sport didn't want it published. I've got it.
Oh, really? Wow.
We're going to do it here too.
Okay.
Taking 10 years. Yep.
Next question.
Yes.
Why a reformer? Why reformers?
What the reformer does is actually provide a closed chain. All right. So it's closed chain kinetic load. So what it's doing is providing proprioceptive input into the system. People talk about motor learning, but the only way you learn is by having a task. So I say to people, if you're doing exercises on the floor or just open chain exercises and that, it's like sitting in a chair trying to learn how to drive a car. There's no decision making for the brain and the system to actually respond to. So you've got to get in a car to learn the motor patterns of how to drive a car. So this is the thing with the reformer. It's actually providing it. It's spring loaded, but it's actually providing that input. And this is where it's a sub-maximal input, not maximal input. So it's how you control. You're going for high repetitions, but moderate load. And this is more the endurance and more motor control. That's how the system then learns. And it actually goes from cortical to subcortical. And we've proven this as well. We're looking at some transcranial magnetic resonance MRI at the moment is the next step. That's another project with a postdoctorate to look at what happens cortically and then what happens subcortically. And that's why we're doing work with brain trauma and stroke patients. So,
wow. Okay.
Same thing.
So on that note, just so, for example, if you have a runner, how would you assess them using a reformer, for example? Back pain, which is a very common one, Pilates and spinal postural issues.
Oh, I've got one right now. He's a marathon runner. He's about to go to the UK, to the US. He's got a scholarship in the US and he's got a hamstring problem, which they've been trying to work out. And it's not working. It's still problematic. But with a runner, we can say, okay, and he's, as I said, marathon. So the first thing, a marathon runner doesn't need strength training. He needs endurance training. So there's the first thing. So we've taken him off his strength training program to put him on an endurance training program. Completely different muscle fiber type 1, type 2, keep it simple. So that's for one. Now he's only got the hamstring problem on one side, but it's also in his knee. And it's also in his glute on that same side. With him, in fact, he's much better running on the flat. He hates going up hills. It gets worse, and that's when he's in flexion. Downhill, he can actually accelerate. He's faster going downhill. He's in relative extension. So it's using that directional load into his program, getting him to run with a greater lordosis, get him off the hill training. And that's when it all started. They started getting doing uphill sprints, which involves a lot of heavy duty flexion loading. And that's when the problem started. So we're backing him off and giving him a directionally biased program, which is showing good results already within a week. A week. That's a problem that's been going on for about 2 years now.
Wow.
So we know it's not his hamstring muscle because the hamstring tear's healed, but this is what we see with recurrent hamstring problems. People keep focusing on the muscle and they don't look at the whole system.
Oh, wow. Very interesting, isn't it? So this can apply to basically any injury.
Yes. It's been very encouraging, as I said, even with the upper limb, when you start looking at sport, and one of the things that's come out of some of the UK sport stuff that we've done is actually non-specific sports training. And that's where the trauma comes into it. So the repeated trauma of their training is what's causing the problem. So you've got to offset that, and then you've got a better outcome, which we measured with GB, with the rowers, on a patient-specific functional scale in the ergo, and they were the measures to say whether you're in the boat or not. I was taking their strength and conditioning program, but each one of them had a different program based on their directional preference. So they're only doing flexion to the right, flexion to the left, extension to the right, or extension to the left.
So it's not a bilateral. It's not a bilateral SLP program. Interesting.
Definitely not. How many sports are unilateral? How many sports are bilateral? Most sports are unilateral. And it's right in front of you. The injury rate comes from the fact they're given bilateral training.
Wow. Interesting. Anyway, so how do
You did?
they find out more about what you do, like physios or the audience here? Like,
Oh,
want to learn more about these papers or content? Do you publish anything anywhere? Yeah.
it's online. It's on PubMed.
Yeah.
I can send you the references. We've got some of the references online on the Clinical Pilates website, DMA Clinical Pilates. If you look at the education, some of the research papers are there. We're going to put some more of them up. We've got I don't know, 20 odd papers from about 7 or 8 universities and more in the mix. So there's a lot of information there. We run the education that's been going now for, Mike Kenahan, you work with Mike, don't
Yeah,
you?
I do.
Yeah. He's the person who helped start this with me.
Interesting.
When we were transplant medicine 38 years ago,
Oh,
I was
wow.
talking to Mike again recently and I said, have you heard about Pilates, Mike? He just rolls his eyes. He said, what happened there? I said, I don't know, mate. You helped me start something.
Nice.
And it
So,
refuses to go away, which is great.
hasn't gone away. It's gone bigger,
Mm.
which is awesome. So, no, it's really interesting this. And so, I'm going to ask you, what is your plan for the next 3 to 5 years for your career?
My wife wants me to retire.
Doesn't sound like you are, based on what I'm seeing at your.
I'm trying to back off. But really,
Yeah.
and this is the thing, as I said, keep raising the bar. There's a lot of people doing Pilates now. So to think of how do we step physios up to that next level. So as I said, we've got a huge network of physios and clinics. There's 7,000 or 8,000 clinics in Australia using clinical Pilates. It's one of the biggest things that physios invested in ever. If you look at the cost of training, equipment, infrastructure, there hasn't really been anything that's been invested in so heavily by the physio profession that anyone can remember, which is terrific. So it's a case of putting that into play to say physios are doing a better job, and here's exactly why. Having outcome measures, not just doing Pilates classes. That's for gyms and that's for fit people that don't have any problems. Physios have got a very different model. And this is where we have a treatment management and then the long-term maintenance model, which you can then put them into groups and classes. But the first 2 phases legally are what you critically have to do is prove that you have a treatment model and a plan. So we've developed that and developing that further right now. As I said, it's just been put to the test with a PhD. Anyone want to do a 3-arm PhD?
Yeah, reach out to Craig.
Yeah.
Yeah.
Yep.
Yeah. So, what advice would you give to a new physio if they want to sustain a filling career like yourself and probably a very financially successful one too?
Yeah.
Right now, what advice would you give next generation physio? Craig Phillips, right?
What's your point of difference? That's the first thing. We do a lot of physios. When I went through uni, there was 5 universities doing physio. We've now got, I think, 34 in Australia. It's the largest proportion training of the entire medical profession is physio, more than medicine, more than OT, more than speech, more than diet, more than dietary. Physio is number 1 out there. So there's huge competition. But I say to young physios, set yourself a 5-year plan. Where do you want to be in 5 years? Because that's the first thing. Put a stake in the ground. Here's what I want to be in 5 years. So it's a career plan rather than just having a series of jobs. I'll say that to physios. Do you just want a series of jobs or do you actually want a career? So that's my first thing. As you said before, the 5 to 7 year turnover, I already hear undergrads talk about the fact they're going to be out of the profession within 5 years.
Really? Already?
Already, yeah.
That's
before
sad.
they've even graduated, I talk to final year students. They keep asking me back. I'm a bit like Ricky Gervais. I say something more outrageous every year and
Okay.
they want some more. But they're already talking about the fact that the attrition rate is this high, but you still got to pay your HECS debt. I think the big thing, as you said, financially, is physios actually understanding how the healthcare system works. None of them do. They're never taught this at university. Do you know what a risk equalisation pool is? No. That's in the private health insurance. Risk equalisation is to do with the amount of money paid out from a common pool of funding in the insurers for high risk patients. But there's a lot of things in healthcare that people do not understand, particularly in physio, and that's why physios get paid so badly. There's huge amounts of money being carted around. Physio gets very little of it. Physio's got the greatest impact. What's an average surgical cost, Barry?
20K, 15.
30. Oh, yeah. 30 is conservative.
Okay.
$30,000, not including opportunity costs and all the other stuff that goes with it. So one physio stops a surgery, that's about $30,000 saving. But if you've stopped 5, and we've been documenting this now for quite a few years, the average clinic can stop 5 to 10 surgeries a month. And we're talking menisectomies,
Serious
FAI,
stuff.
labor,
Okay.
all the easy stuff,
Yeah.
all the stuff that's been proven ineffective.
Okay.
I saw a menisectomy yesterday. Well, we've known since 2000 for 26 years that menisectomies are low value. I had one come in. But $20,000, $30,000 procedure. So an average clinic can stop 5 per year 5 a month without much effort. So if that's 5 to 10 a month, that's 50 to 100 a year, 30,000, that's $2 to $3 million saving per clinic per annum.
It's interesting that lens that you're putting. That's high value
It's very high value. And this is where
for a clinic. For a clinic. Yeah.
When you get 100 clinics doing that, and you've got $2 to $300 million saving just in surgical costs, you get 1,000 clinics, we're getting some serious numbers.
So it sounds like, sounds like you're probably good with health economics or better as a physio with numbers than most of them. Is that right?
It's just common sense. If you just look at it and go, I've stopped a person having surgery, well, and this is where the value of physio has not been out, but 1,000, and there's more with a lot of them too, is pretty standard. But we see people going off and have 2, 3 or reconstructions. My best one at the moment is patient hasn't turned up yet, but they've had 18 revisions of a knee replacement. 18. So if you look at that in dollar terms, you're looking at 30,000 by 1820. There's $600,000-$700,000 worth. Just endless amounts of money can be spent. So physios need to get into this to actually get in there and not $500 a year from their private health insurers. Actually, some serious numbers on their benefit and their value. The money is there. Oh, I've lost your volume.
Yeah, the money is there, Craig.
Oh, sorry.
Yeah. The money is there. You just need to know how to mine it, don't you?
That's what we're not doing as a profession. There was $500 million given to primary health care the other day by the feds. $1 billion. How much of that's going to be going to physio? None, if any.
Jeez.
That'll go. $500 million. That was probably a week, 2 weeks ago, in the last 2 weeks. But physio won't get any of that I'm aware of. So
But should we be getting more into politics and things in your
absolutely.
belief? Yep.
Absolutely. And we had this a while back. There was a period, trying to think when, 5 or 6 years ago, where they were saying Pilates has no evidence. And
I remember that. And then they tried to change, like where they didn't want to fund it, private health.
Yep, correct. Do you know how long that lasted? 6 days. 6 days. That was turned over and repealed within 6 days. Because the health minister, Greg Hunt, at the time, somehow he got a hold of a whole lot of research, appeared at his office or in his letterbox in Mount Martha or somewhere. Okay. I don't know who did it. Yeah, because here's all the evidence. Here's 7 major institutions that have done the research. Here's 7 major institutions that have proven its efficacy. And that was turned over within 6 days. And the thing called NETREAT, Natural Therapies Review Expert Advisory Panel, was put in play to decide what to do. That's been about 6 years and they haven't said much. But a couple of $1 million was spent on that decision-making tool, which has made no decision. But this is the stupidity of the whole thing, of the politics. Actually, physios should be in politics. Physios get left out all the time.
So what's
left?
So how do we get involved? Are you involved on that side, or?
I am involved, but I'll be careful what I say.
Of course.
Because if we look at it, physios have the closest contact with the public on health every day. Surgeons don't, doctors don't, GPs don't, nurses don't, specialists don't. Physios do. Physios will be seeing patients 2-3 times a week. There's no other area in the health professions that has that higher contact with the general public. So physios, educating the general public about the health system and where their money lies is the first step. Stay tuned because there's more to come from this. Yeah.
Okay, yeah.
Demanding value for the money. I don't want surgery. I want conservative care. Don't give me $30,000 for surgery. Give me $30,000 for conservative care. And the money is actually there. It is
Thanks.
actually.
No, thanks for that. Thanks for those thoughts. But I hope others will take some of that, reflected.
I might end up under a bus. Yes.
What's that? No, but I've always had that feeling that we needed to be more representative at that level.
Oh, yeah. Yeah, we're missing people. They talk about keeping people out of hospital, but there's no funding to keep I work with quite a number of major public hospitals in Australia where we've got clinical Pilates in the outpatients department in these hospitals, but you can't refer patients from a public hospital into the private sector with any money attached. There's no funding. There's no funding to do that. And it drives the public hospitals crazy because the government doesn't allow it, but they can put them into a hospital bed at $2,000 a night as an inpatient without batting an eyelid. We've got the highest hospitalisation rate in the world in this country. We've hospitalised, and this is from the AIHW, we hospitalise 11 to 12 million hospitalisations per annum. That's half our population hospitalised every year.
Anyway, so when do you start the political party helping you fund it? I'm just joking.
I'll call it one healthy nation. Yeah.
One healthy. Anyway, thanks for your time and thanks for sharing those tips for
That's all right.
the audience. And
Enjoyed it.
I really enjoyed it too. It was a
Thanks,
clinical
Barry.
one too, but it mixed kind of what physios should understand about the actual health system they work in, and they shouldn't just give up and move, become doctors and do MBAs or work as an OC health provider.
I talk to a lot of doctors. I've got specialists as friends, surgeons.
Yep.
I'm working with another PhD. We've got a GP doing his PhD on the chronic pain, what they call autonomic disturbance. And he's a GP and he's heavily frustrated and he's older and grumpier than I am. A chap called Graham Exelby. Look up his research. He's blowing apart this chronic pain thing as well, working with physios. So yeah, there's a lot of guys we're involved in. There's quite a group of us trying to make a noise. Yeah.
Thank you. Thanks, Craig.
Everyone's doing bloody Pilates. This is good.
Thanks, Craig.
All right, mate.
Thank you.
Thank you.